It is an honor and a privilege for me to be here today talking to you about novel therapies for Hodgkin lymphoma. And thank you to the organizers for having me here. As a means of background, I want to tell you that, and as you already know, Hodgkin lymphoma is a B-cell malignancy that is highly curable. Salvage is with autologous stem cell transplant is the mainstay of treatment for relapse refractory Hodgkin lymphoma. And for patients who do not respond to salvage chemotherapy or relapse after autologous stem cell transplant, unfortunately, the prognosis is very dim. Results of allogeneic stem cell transplantation in this population remains disappointing, with high non-relapse mortality. And when low intensity or reduced intensity conditioning allogeneic stem cell transplants are done, there remain high rates of relapse. So, as you know, conventionally, we treat Hodgkin lymphoma with chemotherapy, which is cytotoxic. It targets rapidly dividing cells, mostly cancer cells, but also non-cancer cells. So you end up with hair loss, intestinal damage, nausea, etc. And unfortunately, over time, the cancer cells develop resistance to chemotherapy. And another problem is that it's not specific. Then there is radiation therapy, which remains important in the treatment of Hodgkin lymphoma, which are high energy rays that damage or kill cancer cells. But as you know, not only cancer cells. And so there's a risk for secondary malignancies later on in life, particularly breast cancer for girls that receive radiation to their chest. And then, and this is what I'm going to focus my talk today, there is targeted therapy and immunotherapy. Talking about targeted therapy, this is a type of treatment that uses drugs or other substances to identify and attack specific types of cancer cells with less harm to normal cells. Some targeted therapies block the action of certain enzymes, proteins, or other molecules involved in the growth and spread of cancer cells. As you can see, for this Hodgkin-Reed-Sternberg cell, targeted therapy will attack some of the proteins on the surface, or in the inside the cell, it will target the signaling pathway. And as you know, Hodgkin lymphoma is an NF-kappa B-driven malignancy. And then there is the microenvironment as well that has to be taken into consideration. So the different types of targeted therapies are, for on the one side, cell signaling targets, HDAC inhibitors that will impact directly the transcription and translation of proteins. And those would be vorinostat, panobinostat, and mosetinostat. We also have mTOR inhibitors that act here, and the most important one being everolimus, though everolimus has other actions as well within the microenvironment. We then have microenvironment targets like rituximab, though this would really, and we'll talk about that in a second, more into immunotherapy. And finally, immune modulators like lenalidomide. So immunotherapy is a type of therapy that uses substances to stimulate or suppress the immune system to help the body fight cancer, infection, but also other diseases. Some types of immunotherapy only target certain cells of the immune system. Others affect the immune system in a general way. So the types of immunotherapy can include cytokines, vaccines, and some monoclonal antibodies. So we'll talk a little bit, we'll start talking about what we call the checkpoint inhibitors, which are the PD-1, PD-L1 ligand inhibitors that interact between the Hodgkin-Reed-Sternberg cell and the cytotoxic T cells, and therefore facilitating T cell activation. There are many different checkpoint inhibitors in the market: nivolumab, pembrolizumab, sintilimab, tislelizumab, camrelizumab, and avelumab. They all have similar profiles as far as response. And then there are the side effects, the most common being hypothyroidism, fevers, rashes, diarrhea, transaminitis. And very specific to checkpoint inhibitors would be the immune-related adverse events that can differ between the different classes. And also these types of therapies can have immune-related, if infusion-related reactions. Some of them have already, like nivolumab, has already been taken frontline. So in this frontline study from Germany that was just published last year for early stage unfavorable classical Hodgkin lymphoma for stages 1, 2 with either a bulky mediastinum extranodal extension or and a sedimentation rate greater than 50 if the patient has no B symptoms, or greater than 30 if he does have B symptoms. And we see that the survival curves are phenomenal. So these patients received, this was a randomized study where they either received 4 times nivolumab AVD plus radiation, or they received 4 times nivolumab, then two cycles of nivolumab with AVD, and then 2 more cycles only of AVD plus radiation. So they all got involved site radiation. Right around the same time, a little bit earlier, was this study published for advanced stage Hodgkin lymphoma. This is the Checkmate study done here in North America for stages 3 and 4, and for stages 2B that either had a bulky mediastinum, bulky peripheral node, or extranodal extension. And also here you can see that the results are phenomenal and the treatment was given here in a 4 times nivolumab, then 6 cycles of nivolumab AVD plus 30 gray of involved site radiation. You see the numbers are small. These are still small studies, so it has not yet moved into the mainstay. But also in children and young adults, there is currently one study open, and that is the Keynote 667 that is run in North America and in Europe. In North America, the cohort is for low-risk patients, where they get 2 cycles of induction. And if they are slow early responders, they get 2 more cycles of AVD plus pembrolizumab, and then get continuation pembrolizumab every 3 months, every 3 weeks, excuse me. But all of them get radiation, whether they're PET positive or PET negative. In the German arm, they chose only for a high-risk group. So patients that are slow early responders after 2 cycles of OIPA continue with their 4 cycles of COPDAC and then get response-based radiation, and also they also get maintenance with pembrolizumab, and they received concomitant pembrolizumab with their COPDAC. The next category that we will be looking at is the ipilimumab, which inhibits CTLA4, therefore facilitating the interaction between the co-stimulatory CD28 from the T cell and the B7 receptor from the Reed-Sternberg cells. It has been demonstrated that T cell exhaustion and deficient anti-tumor immunity play a key role in propagating a permissive milieu for classical Hodgkin lymphoma. So this is a promising approach as well to taking care of Hodgkin lymphoma. The early phase studies did not show, were not quite as exciting with ipilimumab by itself. So this is a pivotal trial in which it is given in combination, and it is given in combination with brentuximab vedotin, and it is so here it would be the ipi plus brentuximab, nivolumab plus brentuximab, or the 3 combined. And as you can see, it appears that this triple therapy is the most promising of these all. And here are the waterfall charts of these therapies. We continue with the brentuximab vedotin, which is an antibody-drug conjugate directed to the CD30, which you are very familiar with. Frontline, this study has shown quite quite some impact in low stage, limited stage classical Hodgkin lymphoma in the adult world, where they have given sequentially A stands for brentuximab vedotin plus 4 cycles of A plus AVD. And here you see, though this were only 34 patients, the results are remarkable. And for stage 3 and 4, the Echelon 1 study, a much larger study, has also shown that there is a clinically significant and statistically significant difference in progression-free survival for the group that received brentuximab vedotin versus the one that didn't. As you see in the brentuximab vedotin arm, the bleomycin is omitted to prevent pulmonary toxicity that has been previously described. And this is a large study with over 600, almost 700 patients in each arm. But also in pediatrics, brentuximab vedotin has found its entry, and the recently closed AHOD 1331 study from the Children's Oncology Group tested brentuximab vedotin with AVE-PC in a randomized fashion versus ABVE-PC, which is their historical approach, and they have then proceeded with radiation according to response, except that large mediastinal masses and slow responding sites got radiated. And at St. Jude and in the Stanford Dana-Farber consortium, we tested 2 cycles of AIPA plus 4 cycles of CAPDAC, and only sites that did not have an adequate response involved no radiation. This trial is about to be published in the next few days when you see this presentation. Brentuximab vedotin in combination with therapies for relapse refractory, particularly combination with bendamustine, is the one that we like to use preferentially, but you see all these other combinations are certainly acceptable and have good results. Brentuximab vedotin as consolidation therapy in the ATHERA trial has proven to be successful in maintaining prolonged remission, though the overall survival does not seem to be affected. I want to talk about CAMI-T, which is an antibody drug conjugate directed at CD25, the alpha unit of the interleukin-2 receptor. It is conjugated to a pyrrolobenzodiazepine dimer toxin, and studies are still very early. And so I could only find this poster that was shown at ASH in 2017, and that shows on 27 patients with Hodgkin lymphoma, overall response rates of 78% for the first cohort. And when they added for patients that were part of the first and second cohort, the overall response rate was 100%. There is a new bispecific trivalent chimeric antibody construct, the AFM13, which is designed to recruit NK cells via the CD16 receptor and attaches to the CD30 on the Hodgkin-rich Sternberg cell and facilitates an immune response. There has so far only been one phase 1 study that enrolled 30 patients and showed an overall response rate of 83%. And then finally, the CD30 CAR T cells, and these our preclinical studies have demonstrated the efficacy of CD30-directed CAR T cells in eliminating T cells in vitro, particularly with co-stimulatory domains. Phase 1 trial with a CD137 co-stimulatory domain that enrolled 17 patients showed an overall response rate of 39%. Another one with a different co-stimulatory domain showed a CR rate of 51 and a 1-year progression-free survival of 36%. And for those patients, though, that achieved a CR, the progression-free survival was 61%. And finally, there was another trial with both CD28 and CD137 co-stimulatory domains that in Hodgkin lymphoma patients, of which 7 had a CR, but 4 eventually relapsed. So in summary, Hodgkin lymphoma is a highly curable disease particularly in the frontline setting. Relapse in patients with resistant disease remains an issue, though the advancement of brentuximab vedotin and checkpoint inhibitors frontline have significantly improved the outcome. And patients refractory to immunotherapy require other options. Cellular therapy appears to be a safe and promising alternative currently being studied. And with this is a view of my walk to work this year in February on a day that we were surprised with snow here in Memphis, Tennessee. Thank you very much.